Upgrading the history. So this is my tutorial on how the different models of history taking have evolved since the 1970s, actually, to add to the medical model, simply. So I thought I'd begin with the history itself. So the medical model that most of us are taught, at Warwick, we were taught the four frames. So you've got your history, the presenting complaint, and the red flags, past medical, meds, allergies, social-ish, but not quite regimented. What do you add in the social history? What is the social history? And then ICE, literally being 3 questions on the end for 25% of your marks. But what do you do with ICE? And how can you adapt to ICE and all this kind of things? So how do we go a step further with this history? So GPs love their models. There are lots and lots of models. This is a little timeline. Let's start with the first one. So we've got the triaxial model. I've got some lovely abstract pictures, all from Unsplash. So let's crack on. So the triaxial model. So this was in the early 70s. Extend thinking beyond the purely organic in 1972. Okay. So this is the mainstream introduction of the social history to medicine. So it predates Engel's 77 paper on the biopsychosocial history. Really, this is just where the third frame comes. There's not really much to say from this apart from take a social history every single time. I think a lot of clerkings would be better in hospital if on the front end we had a better appreciation of the psychosocial history, because we could probably get balls rolling. I wonder if this would affect discharges. The second one here, the health belief model. So this is 1975. So it's intro of ICE from a TB eradication program. So this basically said, okay, from the TB eradication program, what worked? And they found that there were 6 pearls for improved concordance. So when these are met, then outcomes are improved. So if the patient thinks they are at risk of having the disease in the first place, if they know the biopsychosocial consequences of actually getting this disease, right? And then if they believe that the treatment could actually help them, that's a biggie. And we're talking about the difference between cues to action and the locus of control. So big words there, or complicated rather, and both are intrinsic and extrinsic. So in terms of our cues to action, okay, are they an internal or an external thing? What I mean by that is, so internal would be the symptoms are really bad, so my cue is to seek out help. Or extrinsic is the symptoms aren't that bad, I'm kind of putting them off, that lump, that won't go away, but my wife is forcing me to go. All of these affect concordance because, shockingly, intrinsic is more likely to meet something if you do not change the way that you approach the extrinsic beliefs. And then locus of control is intrinsic and extrinsic. Do you believe you have a solid, stable base, or are you dependent on that doctor to do everything and to give you everything? And, the social structure, like have you been institutionalized in a hospital, etc., etc. So always think about those 2 categories, okay? When you're planning, where is the patient? Are they intrinsically or extrinsically located? Number 3, the 6-category analysis model. So, 6-category analysis model. So, Heron in 76 had 3 approaches between the doctor and client, right? So, the number 1 was prescriptive. You tell the patient this, you have this, you're getting this, take it, done. The second one is informative. There's more balance given. There's a choice of options. There's a choice of even differentials discussed. And then confronting approach. And this is actually appropriate confronting, okay, so an appropriate challenge to the behavior. Catharsis, where you're basically just allowing the patient to release how they're feeling, versus catalytic, so you're encouraging latent things to be brought in. So you have a positive relationship, the patient's more likely to disclose things to you, you're catalyzing that with that relationship. And then support to validate and comfort. Now, the reason that I bring this up and the reason that Heron talked about it so much was that you've got to factor that you're kind of like a mixing board. You have all 6 going at once, and it's what percentage are they going up by. So for this, be aware that you use all 6 in every consult. There will be times where you're telling the patient, there'll be times where you are working with the patient, there'll be times where you're letting the patient vent and that kind of thing. And if you're going the wrong way down a consult or you're getting stuck, just be aware, am I stuck down one of those avenues and the others are really dimmed on that dimmer switch? The next one is the Bain and Long model. So, 4 years they listened to thousands of tapes of hundreds of GPs consulting, and there were 6 asks per consult. The first one was obviously establishing the relationship, discovering reasons to attend, as well as conducting the exams, conditions together being considered, detailing the labs and the management, and terminating. And then they added a 7th one called the doorknob effect. Now let's expand on this a bit. So the ones I've underlined are the ones where things tend to go wrong when you're consulting with patients in clinics, okay? So discovering the reasons to attend, and that's why you end up with a doorknob phenomenon, where they're on their way out, they've got their hand on the doorknob, it's the last second, oh, doctor, just one more thing, okay? So you've not discovered the reasons to attend, so that's a non-efficient failure, which is not equitable for the rest of your practice, and it can be frustrating, so you're not meeting the best, okay? The other thing is considering the condition together. Have you been doing that? Have you been doing shared decision making? It's not just because we're in a modern age and it's not appropriate to be paternalistic. It's because outcomes are better when you are not paternalistic. When the patient is bought into the diagnosis and the plan because they have had an active role, better outcomes result. Okay? So the Bain and Long model, reason for attendance, get it solidly found and consider together. Okay? The next one is the Scott and Davies model. So 4 areas explored every time. So you've got the acute, but you've also got the chronic context, so that comorbid list. 2 things that you should also consider here is to educate the patient on conservative management. There is always conservative management that can be done for every single diagnosis. So, we think conservative medical, surgical, specialty referral. You need to also think, okay, am I actually doing conservative management? Right? Am I actually doing conservative management? And what is evidence-based conservative management for a lot of the things I commonly see? Am I imparting it? Are they remembering that? How does their locus of control affect the ability to be concordant with that? Are they just saying that? How well do you know this patient to know if they're just saying that? Right? Then consider prevention. So there's always an option, whether it's primary, secondary, or tertiary prevention. You always have the option to do some rate-limiting intervention here. So that's the Scott and Davis model. So always consider prevention in your patients. Now, the folk model, I really like the folk model. So this was from anthropologist Hellman in 81, who stated the patient comes in with 6 key questions. This is particularly good for that patient who you don't really know what's going on. You're a bit confused. They've got medically unexplained symptoms, or it's something that's chronic, progressive, that you cannot cure, which is most things in today's modern healthcare system. So 6 key questions, and they spell Hellman in my mnemonic. So happened. What's happened, doctor? What's caused it, doctor? If I left it, what would happen? Me, why has it happened to me? What is the action plan, doctor? And why has it happened now? So if you're really trying to validate the patient and give them a holistic understanding so they know what's going on, you have to hit Hellman from Hellman in 81. So the folk model here, it's great for the medically unexplained or confused situations. Next one, number 7, Pendleton model. So the Pendleton model, the bigwig social psychologist, beloved by the Royal College, named 7 tasks per consult. The first one is reason to attend, then others to the comorbid context. There's a problem list, engage in shared decisions, equitable resources, and sustain short and long-term relationships. I bring this up because Pendleton's beloved by the Royal College. A lot of your portfolio competencies are based on this, like COTS and things. So just have a read of the Pendleton model. It will give you a few marks. Use this for COTS. He is beloved. Problem-based interview model next. So focus on psychosocial distress. It's a big focus on the distress. So you've got to sense the problem, because often the distress is not explicitly said. Sometimes it is. If you're in the crisis team in psychiatry, as I was as an SHO, then it is often. But usually it's not. So you've got to sense that there is a problem. You've got to clarify and then explicitly bring the implicit to the real surface, right? Allow that patient to vent, negotiate the next steps, have a shared plan of attack. So it's focusing on that distress. And why have I got that background? Because sometimes the distress has to frame the whole arc of the consult, so give ice early. Because if they do not feel validated and seen, understood, and appreciated for that distress, they are not going to open up to you. The McWhinney model. I love the McWhinney model. So the McWhinney model, think about your 2 arrows, okay? So in Ontario in the 80s, transformed clinical method. So this is where the doctor weaves one arrow with the patient's, their arrow, to meet shared goals. I like to think of this as, if the doctor comes in with the biological view and very little knowledge of the psychosocial of a patient, particularly a new clerk, right? The patient will not have a lot of biological knowledge, usually, but has a lot of their own psychosocial knowledge. So you have got to make sure that both arrows are pointing to the end of the consultation. And as doctor, you have to bring in the biology, but you have to continuously weave and drop into their psychosocial. So the whole point of this is that you should be weaving the psychosocial organically throughout pretty much every frame. So it's not just consigned to ICE or the social history, right? It should be weaved between, because you're getting validation, which means that when you get to the social and ICE, when the social and psychology become the actual tenets of the history, that they have already felt the groundwork of validation and an opening to express this stuff. So the McWhinney model is, I think, is really good. Weave the biopsychosocial from the beginning. The Neighbour model, Neighbour's really famous. So Neighbour is a Watford-based GP. So 5 intuitive checkpoints, not points. That'd be nice for where next. So Bix, like the pen, that's how I remember it. Build up your rapport with the patient, so important. Rapport equals good history, okay? ICE, as we said, control share. So make sure that you are steering the conversation, but that they are your co-pilot. Safety net, and then this is a big one. It's metacognition of yourself. Are you in good enough shape for the next patient? Are you ready? You should ask yourself that, and you should not assume that you are, right? You should not assume that you are. So safety net, and are you in the right shape? That's what I've taken from this, the S's. So the Tate model. It's not affiliated with the Tate. I'm just in Liverpool and really like that picture. So the Tate model, I think we're in the 80s now. So this is another GP bigwig with Pendleton. So he brought video consultations on giant cassettes with giant camcorders. Videoing consultations. And a big thing that he likes is understand their understanding. So you should always end a history by getting the patient to reflect back, just so we're on the same page. How about you just summarize to me what you think is going on and what we're going to do about it? Film yourself at all stages, as we can always improve. It would be really nice if some of the senior doctors I'd worked with in my life had the consultations that I have seen filmed, and then a panel of their peers had talked to them about it. That would have probably been quite useful. And then economics as hidden issues. So one of the greatest, most potent social determinants of health are poverty. Think about debt that is mounting every month and what that does to you. Your sleep, your energy, your focus, your priorities. It's crushing. And we are still a profession that is dominated by people from middle and upper middle class backgrounds who, frankly, only know the theoretical side of poverty. And that is changing somewhat, but there is still a disproportionate link to parental income for the average medical student, certainly doctor. So economics as hidden issues, always in the back of your mind, and actually you've got to ask about it. So film finances and flip it back for understanding. Calgary, Cambridge could be 3 lectures in and of itself, so I'll just pull out a few pearls because there's like 75 nuggets of wisdom in this. So one of them is the beloved 5-point model of the history. So give a good golden minute, just let the patient talk. How can I help you today? Boom, off they go. And then prompt them to continue in their own language to tell you. The good historian who's been doing this for a while is automatically ticking off in their head bits of the 4 frames that the patient's already answering and modifying how that 4 frame is going to go, as well as the differential in frame 1. So Add impact. I really like adding impact. So ICE should have two I's in it: ideas, impact, concerns, and expectations. Um, and use the word impact. So instead of, you don't say what are your ideas, what do you think is going on, and how has this been impacting you? How is this affecting your life? Like, that is a big thing. Like, oh god, this is really affecting my life because I can't go to work and I'm running out of money and I'm really struggling. Like, or I can't sleep and so I can't focus on my kids, so I'm feeling like a rubbish mum. But these are things you hear, right? And they might be more worried, and they often are more worried about the impact than the actual disease process itself, right? So the exam, as we well know, explain. So the explanation is about information, the recall that you can then help them with, understanding, and putting ICE into the management plan. So you think it's this, but because of what we've done so far, I think it's probably not that. It's more likely to be this because of that. You're worried it's this. Now, I agree that's a concern. So we're going to do this little poo test. It's called a fit test, and we're going to get some bloods. And if it's above the number 10, then we're going to refer you to the iron deficiency clinic, etc., etc. Expectations. So you think from this that we need some antibiotics. I don't think that's necessary because of this. Imagine how much more validated you'd feel if you are quoting their ICE in the management plan. Close with summaries, safety netting, and a shared contract. So it looks like you need to do this. I'm going to get this blood form done for you and get this thing sorted. We'll come together. I'll follow up. I'll give you a phone call in a few days, make sure you're okay. And if you're not, you've got to let me know, okay? Like that kind of thing is really a shared contract. Impact to ICE. So use a second I, right? And use ICE in the plan. Test their understanding, and make a contract. I like that. So the Barb model. I love her face. Look at that. Honestly, that's so funny. So the Barb model, I'm not going to sing it too, don't worry. So it's the doctor-patient relationship can be hacked to help both. I love this next line. How the patient behaves depends in large part on how the doctor behaves. Now that's big, isn't it? And what's the state of your room? What's the state of what you're wearing? There are lots of proxies of authority and responsibility. There's a lot of psychology into how a room is set up and the state of the room, right? If a patient walks in and there's still the white paper roll from the previous patient that's got mud from the boots on the side, if your desk is a total mess, if the table is skew, if you're looking at the screen the whole time, you're not making eye contact, right? If it's a state and you look a state, proxies of authority are a big deal. You can't get past that first impression in a brief consultation. You can't. And also, rooms are set up for psychological advantage. So the first thing that you should do is set up the room to facilitate openness and shared decision making. The BARD model. So sort your behaviour and your room out. The next one, the Balint model. Okay, so Balint. So I really like Balint. So in 1950s, Balint with his wife Edna, and I'm including Edna specifically here and not his first name, because she was basically written off by history and ignored in the patriarchal era. So at the Tavistock Clinic, he came up with this thing with his wife. Who has a case today? And they were both integral in this, right? So the opening thing is who has a case today? And people bring cases, okay? And they explore the dynamic of the doctor-patient relationship, not the pathology. And here are some pearls that have come from the Balint model. So you should really go to them because they're really good. There's biopsychosocial in every single consult they've audited. Every single one. If you haven't documented them, then you're not getting the full picture, so I'm booing you. And the doctor can get better at psychological skills. It's not just an innate thing. There's an extent, but you can get better. And you can always get better. Entry ticket. Beware the chesty cough. I was teaching med students, second year med students, a few days ago. And they were talking about the cases that they had had in GP in the previous block. And they were like, oh, we got a relief when the chesty cough came in. And sometimes when you're behind in clinic, fair enough. But often, we have found in the data that patients who come with simple things are coming with simple things because it's not their primary problem. It's their presenting complaint, but it's not their primary problem. And they're looking to test your rapport and test your skills and your ability. And if you get a tick, he knows his stuff, tick, he cares about me, and tick, he understands my background, then they disclose the thing that's really worrying them. And that's the importance of the continuity of a relationship, whether you're a specialty in clinic or you're a GP in clinic, right? Beware the chesty cough, because it's often not just the chesty cough. The next one is patients who have a degree of somatization, okay, and this requires a degree of control taking over their care because they can bounce for years, okay. If they have true somatization syndrome, okay, then what they're going to end up doing is having such medically unexplained symptoms, and they're going to be bounced from specialty to specialty who's going to say, not our problem, and then we're never seeing you again because the joint pain isn't rheumatological, gone, because the shooting pain is not neurological, so gone, right? The headache isn't my problem, not my problem, not my problem. So you have to take a degree of control for the holistic care because no one will. Doctors have feelings too, surprisingly. It's heartbreaking that that needs to be written. I often feel that that should be on the screens of every rota coordinator and maybe even supervisors in hospitals. But doctors have feelings too. The doctor as a drug, I prefer the doctor as a catalyst. Just having a relationship with a calm, compassionate, curious, caring person is therapeutic. The TA model. So why has he put a peacock in? Let's see if you can tell. So there's this idea that came up with the 3 ego states of the parent, adult, and the child. Okay, so at any one point in a consult, we can be in any one of these situations. The parent takes control, paternalistically critical. The adult, more logical and calm. How can we handle this best? And the child, I want that one. I hope it works, more emotionally led. The classic state is parent-child, or if it's standoffish, parent-parent. We want to get to adult, right? And if those egoic states don't resonate with you, then just think of it as how logical, how calm, how much are you two at the same energy level? So I quite like the TA model for that, right? Check your ego and get to the A to A state, adult to adult state. So, NLP, neuro-linguistic programming, I have questions about the science of this. So how the brain handles information, okay, and they came up with the VAK phenomenon, which is visual, auditory, and kinesthetic. They talked about 2 things, which is there are proxies for how people process information, and you can pick those up in consultations. So some people say that if you're looking upwards a lot, it means you're quite visual and you're imagining things, right? You're trying to visualize stuff in your brain and you tend to look up. If you're looking to the side, it's auditory, so your senses are focused in on the ears where the information is coming in. And if you're looking down to your body, it's kinesthetic. In other words, you're focused a lot on the sensations in your body and your emotions. But also the words people use. I see what you mean, I hear you, and I feel you. And so they say if you're trying to validate these people, you should validate them to the type of way in which their brain most likely is handling information in that moment, visually, auditory, or kinesthetically. Great. I'm a bit dubious as to the science, and the research it's kind of pseudoscientific. But I do think the reason I've kept it in here is, number 1, because that picture is really cool. And number 2 is because if you assume that we all are visual, all are auditory, and all are kinesthetic, as well as other things, but it's kind of like, a spectra for each, then you can sort of say, if you're trying to have the patient visualize a certain future, if you're doing a lot of talking, or the patient's doing a lot of talking, or you see the patient remembering something, or you see the patient having an emotive response, then it's important to match what the data is the patient is giving you with the kind of validating message the most, okay? That's just what I take away from that. What does utility? And then the last one is the narrative model, which I've It wasn't by Sachs, but Sachs loves the narrative model. So this narrative model is the idea to focus on the patient's story, so how they perceive their illness, right? So the difference between a disease and an illness. A curious two-way dialogue in the context of the biopsychosocial. You have realistic appraisals that life is complex and dynamic, okay? You need all three. Now, I've just pulled some quotes from two of my favourite books of Sachs. Man Who Mistook His Wife for a Hat. So each of us is a singular narrative which is constructed continually, unconsciously, by, through, and in us. Through our perceptions, our feelings, our thoughts, our actions, and not least our discourse, our spoken narrations. To be ourselves, we must have ourselves possess, if need be repossess, our life stories. We must recollect ourselves, recollect the inner drama, the narrative of ourselves. A man needs such a narrative, a continuous inner narrative, to maintain his identity. And from Awakenings, one must drop all presuppositions and dogmas and rules and honour each patient with individual reactions and propensities. And in this way, with the patient as one's equal, one's co-explorer, not one's puppet, one may find therapeutic ways which are better than other ways. In many ways, he predated all of these models, and certainly the way that medicine was doing it. And it's interesting that no major medical journal contemporarily reviewed his stuff. They shunned him because he was too wishy-washy. And now we've gone full circle. So go Team Sachs. So upgrading the history. So hopefully you've taken a couple of things there. Hopefully there's something in that hodgepodge of information that you can take to add to your history taking. So thank you for your time, and till next time, YouTube.